So thank you everybody for joining us today. My name is Priscilla. My pronouns are she, her, and I work with the Office of Healthcare Equity. So again, thank you for joining us for our COVID community conversations today to answer some questions from the community and be able to share information regarding COVID-19. I'm joined here today by Dr. Chopra and Dr. Pottinger. So I will hand it over to Dr. Chopra to do some introductions. Thank you.
Thank you, Priscilla. Hello, everyone, and welcome to Community Conversations by UW Medicine. We bring you a very important edition in this series today to address some of the most burning questions from the community regarding Omicron and hopefully provide support in the midst of this chaos and anxiety. I'm Anita Chopra. I'm an internal medicine physician at UW Shoreline. I'm honored today to have with me Dr. Paul Pottinger. Dr. Pottinger is the Director of Infectious Disease Training Program. He is co-director, UW Medical Center Antimicrobial Stewardship Program. He's the head of the UWMC General ID section and director of the Tropical Medicine and Infectious Disease Clinic at the University of Washington Medical Center. Thank you very much, Dr. Pottinger, for your time today. Thank you for joining us. We are also joined by Priscilla Estrada, who is the Community and Workforce Engagement Specialist, Office of Healthcare Equity at UW Medicine. Thank you, Priscilla, for organizing the session today. Dr. Pottinger, let's start with this Omicron tsunami. It's in the very first weeks of 2022, we are hit with this tsunami. Can you please talk about what is unique to this virus? Why is it so transmissible? And how is it different from Delta?
Thanks so much, Anita, and thanks for taking a break from seeing patients to facilitate this. I'm sorry you have to Zoom with us wearing the mask. I'm lucky I can go out of my exam room into my little office. That's why I can do it unmasked. But I appreciate your time. The question's a very good one. I hadn't thought of it as a tsunami, but it's true. It's exactly what it is. If we were to look at the epidemic curve, which you folks can find online, remember how worried we were and how stressed we were under Delta, the last variant. What a huge issue that was. Today, that looks like a little pebble, like a ripple in the wave of the true tsunami. The numbers of Omicron infections we're getting exponentially higher than anything we've had. So I appreciate that. Why is it happening? What's different about Omicron? The Omicron variant contains, well, variations, we call them mutations, changes of the RNA, that's the code that makes the virus. Many of these changes, approximately 60 mutations. There's something about that particular series of changes or mutations that makes this very, very transmissible. It holds on to the lining of our upper airways very, very tightly. That means that it takes a comparatively smaller number of viral particles to get somebody sick. The good news in this is that even if Omicron is much more contagious than was Delta, the most recent variant, it also seems to be comparatively less virulent. That's good news. The problem is that because it is so contagious, we have such high numbers of infection, even if those who go on to severe disease, needing hospitalization, ventilation, or to die, even if that number is a smaller minority of Omicron, because the total amount of Omicron is so high, we are seeing, yes, a lot of these complications as well. So I hope that answers the question. This is a variant because of mutations that makes it more contagious, and that's why we are seeing so very much of it today.
So, Dr. Pottinger, if, as you said, it's a minor illness, and if the vaccinated population is well protected against hospitalization and deaths related to COVID, then why is there so much caution and regulation and hoo-ha? And we don't want, we are still encouraging vaccination. Why is that?
Yeah, thank you. So does vaccination help with Omicron? Definitely does. Being vaccinated, especially those who are quote unquote fully vaccinated and boosted, in other words, folks who have, if they have an mRNA vaccine, who've had 3 of those shots, their chance of getting sick is cut approximately in half. Their chance of being hospitalized is reduced about tenfold. Their chance of dying is reduced more than tenfold. So the vaccines still work very well. That's exciting for us because it means that That's a large portion of the population that's less likely to get sick, and if they do get sick, more likely to have a mild course, be able to stay in school once they're through their isolation period, go back to work when they're through with their isolation period too. It is behaving in the way that we have hoped that the SARS-CoV-2 virus would. This is the lesson we had from Professor Darwin more than 100 years ago. It's called natural selection or evolution. What that means is that there's changes that happen every time an organism reproduces. Mistakes will happen. Sometimes those mistakes are bad for the organism. Once in a while, by a strange accident, they will be beneficial. And if they are beneficial, that's the population that will be selected for and will grow. In the case of Omicron, these many different mutations which happen by dumb luck happen to be beneficial to the virus. Remember, the virus doesn't want to kill you, it just wants to spread from person to person, if you will. And so that's what's happening with Omicron. And so that's what we have hoped to see over time, that we would have a virus that is attenuated, meaning less dangerous, even if it's more contagious. And I think that's what we have for this particular wave. So why do we care about this? Number one, I'm worried about future waves, and we're trying to reduce the amount of stress and strain that this is placing on our healthcare system and our society, which is tremendous. And then number two, it gets back to what we talked about before. Even if it's a smaller fraction of people who will be killed by Omicron, because there's so much Omicron, that's still a lot of people who will die unnecessarily. What do I mean by unnecessarily? What I mean is that if we can get everyone to be fully immunized and boosted, and have everyone do a good, thoughtful job with their personal responsibility in terms of covering their face with a high-quality mask, and we'll talk more about that. If we do that, then the impact on society will be dramatically reduced. You may remember with the Alpha variant, we talked about flattening the curve. The idea was eventually people are going to get infected, but let's not all do it at the same time, because when that happens, we don't have fill in the blank. We don't have flight attendants. We don't have people to drive trucks to get our stuff to home delivery. We don't have people to come to the hospital. We cannot allow people to spread this willy-nilly, because if we do, that will indeed hurt people who are more susceptible, more vulnerable to the complications of Omicron. Who are those people? What's those vulnerability risk factors? It's a number of things. The things we think about in terms of immune suppression, people being treated for cancer, people who have a transplantation, people with autoimmune disease. It's also people who are overweight, it's people who have diabetes, it's people who are older, it's people who have chronic lung disease or chronic heart disease. It's a lot of our population who are getting by medically, but this is that proverbial straw that might break the camel's back. We want to protect that group of society, regardless of their income, regardless of their skin color. We want to treat people with respect. And I think getting your immunization, wearing your mask, that's all about respect. Respecting your own health, but also respecting everybody else we're dependent on and in this crazy ship together called society at large. We're all in it together. Let's start rowing in the same direction. That's where this comes from.
Thank you so much, Dr. Pottinger. You really broke it down into, very simply for us, which, to emphasize your point, we still do need the vaccines. Vaccines are still working. And, we do want to encourage people to get their boosters who have not, who have had 2 vaccines, but not their boosters. They should still go ahead and get their boosters done. It seems like every household is affected at this time, Dr. Pottinger. What should someone do if they have symptoms of a cough and cold, especially when testing is so very scarce and difficult?
Yeah, thank you for that question. If you have symptoms of a cough or cold, a sniffle, nasal congestion, muscle aches, fever, if you feel sick, then currently there's a strong chance that that will be Omicron variant of COVID-19. So I would take that seriously. And I think the question you raised a moment ago is a really good one. I would want that person to be tested. I think they should deserve to know, do they have COVID or do they have something else? We would all love to know what's making us sick. That's important for our own peace of mind. It's important for public health too. It's important to know, can we go to school? Can we go to work? So there's many benefits to testing. And there's many barriers. Barrier number one, tests are simply not as available as we would like them to be because there's so many people seeking testing and because there's so few people able to do the tests because so many of them have COVID-19. It's an issue. Problem number two is that each test has its own limitations. Even if you are tested, the reliability of that test may be less than perfect, right? So, having said all of that, I think that if someone finds that they are ill in the manner that you have described, I would want them to be tested if at all possible, but I also want them to assume that they have the infection. Please act in that way, even if you don't yet have confirmation, because that can allow you to help to reduce the spread to your loved ones, to your family members, coworkers, etc. I would put that person presumptively into isolation. What isolation means is that we're no longer out in society, we stay home, ideally isolated from people within our own household too. And we can talk about household isolation as well. But I want that person not to spread it around. Can you leave your house if you have COVID-19? Yes, you can. You can go out and get tested. You can go out for those critical functions. If your physician wants to see you, go and see that physician. But generally speaking, we want to keep you home. We'll talk about for how long in a future question, I'm sure. But I think at least for the period of isolation that we'll recommend, generally that's 10 days, and sometimes we can do less than 10 days if you meet certain criteria. That's what I would do. And I'm so sorry that we are not able to easily test everyone. We're trying to make that easier. There's national, regional, and local efforts to deliver testing, even to people's homes in the mail. At the moment, that is a challenge for folks. So if you have access to a test, use it. But I would also say that if you feel sick in that way, and if the test that you're taking is what we call a rapid antigen test, whether it's nose, cheek, I don't care, in either of those cases, that test may not be positive for the first 3 days of symptoms. So I would still say, even if you feel like you have COVID, whether or not you know that you had an exposure, we're all exposed to a certain degree. I would have you assume that's what it is, even if your rapid antigen test is negative, if it's within those first few days of the onset of symptoms. By comparison, if you have access to a PCR test, one of our molecular tests, those are more reliable early in infection. They're more sensitive. That means they have a better negative predictive value. You can trust a negative PCR test early better than you can trust a negative rapid antigen test, if that makes sense.
So my next question was about the home tests, and you answered it mostly, but together with that question is, can people share those home test kits? Can they share amongst family members?
Yeah, thank you so much. So, home test kits. The idea of doing one test for two people sounds crazy because that's not the way we do things in medicine. And that's the first question that I had heard that coming up. We do not recommend that people do this. Having said so, here's the reason why. If you have a married couple or a household couple who are cohorted together, whether they sleep in the same bed or otherwise, what's the chance that one person will spread it to the other? Less than 100%. In our own experience, it's about a coin toss. About 50% will actually convert that way, and the other 50% do not. So this is surprising to people. They would assume that if one person in the household gets it, everyone will. Sometimes that does happen, but not always. And so if you have the ability within your household to have people sleep separately, to not be unmasked around each other within the same household, please do that right away. If you both become clinically ill, then there's no reason to do so. But you might be able to spare your partner, child, parent, whoever it may be. You may be able to spare them that pain and trauma of so doing. Back to the question of should people swab each other, I have concerns not only around the question of reliability of the test, but also, well, geez, you wouldn't want to spread it to somebody else by sticking your COVID up somebody else's nose. So we generally really do discourage that.
So, Dr. Pottinger, regarding the home tests, would it be fair to say that if the test is negative within the first 2 days of symptoms, should people repeat it on day 5 or day 6?
Definitely, if they feel ill or if they know they've had a high risk exposure, I would repeat that home antigen test later. And you mentioned day 5 or day 6. I think that's quite reasonable. Why? Because early during infection, those rapid antigen tests less reliable. Later in infection, they are more reliable. So I like a positive rapid antigen test. I believe that. The negatives I trust less, especially early on during infection.
Thank you. So, coming to the most important, I think, question of the day is about masks. can you please tell us, are cloth masks still okay? Should we upgrade our masks? And how should we upgrade? And this would be for adults. And also, if you can please briefly talk about kids as well.
Sure. Yeah, I have two kids of my own, although they're grown and basically physiologically adults. So the answer is yes. We should upgrade our face coverings from cloth to something more. There's guidance from Centers for Disease Control, CDC, on this topic about 48 hours ago. And for those who haven't yet seen that web link, I don't know if we can put it into the chat, Priscilla, but let's just guide you folks to latest guide. You can do a web search, latest guidance for masks from CDC. What they've said is that because of the mutations in Omicron, which is by far the greatest majority of infection in Puget Sound, where I live and work, but also nationwide, because it's more infectious, that cloth masks are really just not as good as they should be. We got away with cloth masks as a society for quite some time, although they were never perfect, and we have lost almost 1 million Americans while wearing cloth masks, so I wouldn't say that was a perfect success, but it made a difference. The difference that it makes in Omicron is dramatically less. By converting to a more stringent medical grade type of mask, we can make a huge difference. What does that look like? You've heard about N95 respirators. Here in my hospital, and where you are, of course, we like N95 respirators that are built for medical purpose. And we do that when we're taking care of patients who are undergoing high-risk medical procedures. We call them aerosol generating procedures. We're giving a nebulized treatment, anything that makes fine mist or fog coming out of that patient's nose or mouth. We would want to be in a medical grade N95. But for general use in the general public, a medical grade N95, it can work if you can get your hands on one, that's okay, but it should not be required. Generally speaking, for most public use, wearing something like a KN95 or a KF94 mask that has numbers coming after it, that might be the way to remember it. There are different standards, some from Korea, some from other parts of the world, some within the United States. Those masks definitely provide an increased protection in the Omicron variant. And that's why CDC has said, if at all possible, please, if you need to go outside, if you need to be around other people, let's all try to upgrade our masks away from cloth and onto something more medical grade. It could be a surgical mask. If you wear a surgical mask, we propose that you wear 2 of them because that increases the filtration ability. Or it could be, a KN95. What do I have here? A KN95. This is what I wear to and from my car coming into the hospital. And this is also that level of protection that we would wear just walking around the hallways here within our hospital as well. If we're seeing a patient, we do something a little bit different, which is to upgrade that or to put a second mask on top of it. But just for strutting around the world, something like that, as long as it's comfortable, as long as you're able to wear it without fiddling with your face, we do think that's a better way to go.
And then also just to add to that, Dr. Pottinger, CDC as well as King County Public Health on their websites, they have a list of websites that you could order the KN95s from. And those are very trusted sources and NIOSH tested, masks that people can get. And would that apply, Dr. Pottinger, to kids as well? Would you suggest that they use KN95 masks? Or
Yeah, thank you so much for asking about the kids. I apologize, I forgot to mention that. Yeah, the virus doesn't care how old you are, what the shape of your face is. It's simply there as a risk factor. So yes, is the answer. If we are able to get kids into that level of protection too, I'm very attracted to that idea. I really wish that we had more options for kids with smaller faces, smaller craniofacial structures. I'm hoping that we will start seeing more and more of that level of protection brought into a greater variety of sizes, shapes, colors, pictures on them, whatever it takes to get kids excited about doing it. My sense about the kids is this. In my own experience, and I do advise at my own kids' school as well, I think the kids are fine with it. They're used to wearing masks for Halloween and all of this too. I don't think it bothers them nearly as much as it bothers some of us who are grown-ups because we're insulted on their behalf. The kids generally are okay with that. And to answer your question, yes, children are definitely high-level shedders of virus. And so both to reduce the spread to others and to protect them from others as well, that level of protection in smaller people makes sense. By the way, there's a question that popped up here about facial hair. I'm sporting a beard today. And, does facial hair impact the ability of these masks to work? It can. And there are some beardsmen who wear a very long beard and may not know their own facial features as well. So if I were working face to face with a patient who had COVID-19 or risk for it, I would not have a beard on, for example. But to me, going to and from my car or walking down the street, I'm very comfortable with this very thin level of beard I'm currently wearing. But yeah, I do think that a longer beard could be a real issue in terms of one's own personal safety.
And then, of course, the fit of the mask is probably the most important thing. Even if it's a KN95, it has to fit, snugly. Otherwise, it's probably not, good and protective enough.
It's absolutely true. And I think this is one of the challenges. People want to be safe, they want to buy something, they haven't tried it on. We have this for clothing. You would try on a pair of trousers before you'd pay for them. It's harder to do that with masks. This is a challenge, and I think we just have to recognize that uh, it may take a little bit of trial and error to figure something out. What do I mean by error? If you're wearing a respirator and you happen to wear specs, like I sometimes do, you should do a fit test, and that's a simple fit test. Breathe in, breathe out, have a conversation. Your glasses should not fog. If they become fogged, it suggests that you are letting out more breath than you should. By the way, letting out a little bit of breath is okay, but that implies that other air may get in. So you want something that's going to fit snugly. And Anita, I agree with you, it should be comfortable, meaning sustainable. It should be something that fits tightly, but not so tightly that someone feels they're going to suffocate or they can't sustain wearing that for more than a few minutes of time. One person's perfect mask may be torture to another. And this is just the reality that we live with in 2022. People need to be willing to try things on. And if something fits great, stick with it. Buy more of that. And if it doesn't, be willing to try something a bit different, please.
The next question is, is it true that Omicron protects against Delta infection? Is that true?
Yeah, thank you. We know very little about that because we have so little Delta. In other words, to answer your question, Delta kind of went away. Is that because everybody now has Omicron and they're immune to
Yeah.
Delta? That's a hypothesis. I think the bigger hypothesis is that Delta was outcompeted by this incredibly much more commonly communicated, more contagious variant of Omicron. So we don't yet know because although it feels like forever, we've only had Omicron for a short period of time, if you think about it. So we need more experience under our belt to figure that out. If it turns out that Delta comes back, I'd be very surprised if that were true. Wave after wave seems to be variant after variant. I think we're probably done with Delta, but I don't think we're done with COVID-19. I think there will be future variants that come along, and the degree to which this national experience or an individual patient who's living with Omicron, the degree to which they can be confident that they're now good to go, that they're not going to catch another coronavirus infection. Although we don't know for sure, we're very skeptical that that's true because we do have people who have become repeatedly infected. Now, those repeated infections tend to come a little bit later. There is a temporary increase in one's immunity because there's a lot of immune cells. We call them the B cells, and they make antibodies. When you're fighting off something like Omicron, there's a lot of B cells making a lot of antibodies. That does seem to be cross-protective, we think, against other variants. But that durability, how long will that last? That's what we need time to understand. Time and again, wave after wave coming up till now, what we've seen is that there's a temporary protection lasting maybe between 30 and 90 days, depending on the variant, depending on the person. But thereafter, these people do again become susceptible unless they're immunized, unless they're vaccinated. So it's that combination of vaccinations and for people who've had a breakthrough infection while fully vaccinated, and yes, this definitely happens, those people probably do have a more robust, durable, reliable protection. But again, we're humbled time after time. I cannot answer that question because I don't have my time machine to go forward in time to tell you for sure.
So, Dr. Pottinger, there have been many people who got infected with Omicron after their two-shot series. They
Yes.
were waiting for the booster, and before they could get the booster, they got the infection. What should they do? Should they still get the booster? Should they wait? How long should they wait? Should they get their flu shots? Should they wait on getting their flu shots? This is a very, very common question.
Oh yeah, thanks. Well, this is the easy one, so I'm happy to. You could have started with that to pitch me a softball. I don't mind this at all. Yeah, the answer is yes to both of those. Please, everyone should be immunized against seasonal flu. That's the flu shot. We really think that's important because we're seeing so much influenza this year. Last year, actually, we did not. Flu was outcompeted by COVID. That's not true today, especially in the upper Midwest, where there are explosions of seasonal influenza. So the only thing worse than COVID is COVID plus flu. Please let's not do that. So the flu shot is not perfect, just as the COVID shot is not perfect. Neither one of them will give you reliable, full protection, but in combination with our COVID protection, such as physical distancing and wearing a mask, that stuff works pretty well for flu too, combined with flu shot. So yes, everyone, please get your flu shot as soon as you possibly can. And if you're a survivor of Omicron, that's great. Congratulations, I love that. For the reasons I was mentioning in the previous question, we still do advise, both locally within UW Medicine and our friends at FDA, ACIP, and CDC. All of us experts really feel that it's important to remain protected, enhance that protection, get that booster shot. And I am so sorry for those who were waiting for a booster and got infected while waiting to do so. I would emphasize it's just not your fault. It's just a problem with our supply chain and trying to get boosters into people. You should be boosted after infection. The exact timing is uncertain. We used to say to wait 90 days because our vaccines were so incredibly rare and precious, and that was a good way to steward the vaccines through the process. That guidance has softened, and in my own personal practice, I would say your chance of getting another infection within 30 days of an infection is very small. But after 30 days, I think with Omicron, we don't know. And I would strongly suggest that everyone get boosted, even after Omicron. The exact timing is unsure. You can do it anytime you wish. I would not wait longer than 30 days. If you have access to that technology, please do.
On this note, Dr. Pottinger, the CDC and FDA both approved the booster for teens as young as 12 years of age. Would you recommend that they get their boosters as well? Because some parents are holding off to see if there will be an Omicron specific vaccine. Do you think they should wait?
Thank you so much. I would not wait. And I'm also waiting to see the Omicron specific vaccine that may be coming. My prediction is that an Omicron specific vaccine will probably arrive here just as Omicron disappears. I think the timing is going to be just out of whack. We'll see. That's just my prediction. I could be wrong. Let's find out when we look in March or April. But I think that for the moment, the best technology we have is still very good, if not perfect. It's still very safe, if not completely without possible side effects. So I would definitely get those kids boosted, please. We are seeing huge amounts of COVID-19 spreading, Omicron variant, spreading throughout schools. It's true for kids in sports, it's true for kids in choir, in music practice. Anytime when kids are not coming into school fully boosted, being routinely tested, attesting that they're not exposed, not carefully wearing a mask, all of those layers of protection that work, when we take those away, this Omicron variant will take advantage of that and will spread like crazy. So yeah, no hesitation. My kids are boosted up, and I'm happy about that, and I would definitely advise the same for others, in keeping with guidance from CDC and FDA.
Thank you so much for this clarification. Shifting gears a little bit, Dr. Pottinger, we know that medications like Paxlovid have been approved. Are they now being widely used? Can they be used as, in patients who are not hospitalized?
Yeah, thank you. So the exciting development in 22 is that we have access to newer technologies, medications, and antibodies that do seem to help. But I'll answer your first question, which was, are they being used widely? No, certainly not, because they're not widely available. These are incredibly precious, rare resources, which we have much, much more demand than we have supply. So the good news is that a medication such as Paxlovid, that's one of the oral pills, it's like just a medication, sort of like Tamiflu that we have for influenza, so now we have Paxlovid for COVID. What does it do? It reduces the chance of getting a severe illness or going to the hospital. That was developed and studied most aggressively under Delta, when we were seeing that particular wave. Because Omicron is so new, we're still learning about the benefits of these medicines under Omicron. But we have every reason to think that they will be not only totally safe if appropriately used by a medical doctor, but also that they can help to reduce the chance of getting sick. but because of supply, we have that challenge. Here at UW Medicine, we have a very thoughtful process that allows physicians to make referrals to an internal panel. That panel takes into consideration the risk factors for that person to progress to a life-threatening issue or even to go to the hospital. Remember, our hospitals are so incredibly strained, we're barely able to keep it together. We need to keep people home. That's always true. Home's better than the hospital, but it's definitely true now more than ever because of staffing shortages and other limitations. So these medications can help with that. The reality is we don't have enough. And so this internal panel takes into consideration risk factors to progress, also whether someone has had equitable access to the healthcare system getting up to the time of their illness based on their race, ethnicity, etc. It's a very holistic and ethical and evidence-based process. And based on that, they review many requests for these medicines every day. They are only able to fill a small fraction based on what CDC has called us a tier 1 level of risk. These are our most immunosuppressed at-risk people who may go on to have a bad case of COVID. That might be the medicine Paxlovid. It might be an IV infusion of an antibody called sotrovimab. Those are the two best medicines that we have. Right now, sotrovimab has 0 doses coming to the state of Washington. Our whole state, 0, are expected to arrive this week. That's the reality of this helpful but incredibly precious resource. Paxlovid, we have a handful of doses for the entire state, and each hospital or health system has to make up its own mind how best to use it. All of which is to say, we are grateful to our friends in industry and in federal government who've worked very hard to bring us these technologies. We could really use a lot more. Meantime, please do not anticipate that you can rely on those medications. Those of you listening to my voice right now would probably not fall into category tier 1 because that's only a small fraction of Americans alive today who would be eligible to receive these precious, although beneficial, resources.
Thank you so much for clarifying this. So, for people in the community, your primary care physicians may not have the ability to prescribe Paxlovid because they may not, it's not available. That's something really important for people to know. There's a question in the Q&A. Are patients with primary immunodeficiencies being prioritized for Aeroshield therapy? If so, when will they be notified?
Thank you. So I appreciate that. Primary immunodeficiency relates to people who were born with an error or a limitation of their own immune system. We call it PID, primary immunodeficiency. These are a small number of people, but they're very precious to us because they are very susceptible to any number of different infections. In some forms of PID, that would include COVID-19. That's a good question. Aeroshield, the medication that was requested or asked about, that's a really interesting technology. We're excited about that too. That's a monoclonal antibody, in other words, built in a laboratory, a small molecule that's given to the patient through IV treatment. These microscopically small molecules go into the body and they act as a kind of defense. They build back the antibody that that person didn't have, either because they were not immunized or because they were immunized, but their immune system wasn't able to recognize the vaccine. So this is a way, we call it passive immunization. We give you the antibodies that your body should have made first, Aeroshield. And it's shown to reduce the chance of getting severe complications of infection. So to answer your question, yes, people with primary immunodeficiencies, certain flavors of primary immunodeficiency, is actually a broad group of conditions, but they are considered highly likely to benefit from that technology. Here in the state of Washington, the answer is that there's, again, a very thoughtful way to try to figure this out. There's literally a handful of number of doses of Aeroshield in our state today. I don't have the exact number, but it is a tiny number and much smaller than the number of people with either primary immunodeficiency or solid organ transplant or chemotherapy because of cancer or who've undergone a stem cell transplant. If we take all of our most vulnerable Washingtonians together and try to give them Aeroshield, we cannot do it. Thus, at the moment, there's a lottery process, is my understanding, a random assignment of who will and will not be offered this technology. If you have not heard from a public health authority that you're eligible to receive it. That means that you have not been selected through that lottery process. If you have specific questions about whether you are in the lottery at the moment, the answer is this literally changes day by day. I'm not making this up. As the supply of Evusheld and other of these important technologies becomes available one day, it will ebb and flow day by day. Please do trust, and this is true, and I've worked with our colleagues. I'm not part of that process, but I've talked with them about it. They're very mindful about this. They are super eager to get the technology out there to people who need it the most. So you are probably already in that lottery, and depending on what your tier may be. So more to continue. I think Evusheld is helpful against Omicron, and it will remain helpful, we think, against future variants. The reality is that some monoclonal antibodies work better for some variants than others. And this is part of the endless, what feels like a game of whack-a-mole. We have a technology that works. Number one, we don't have enough of it. Number two, how long will it stay effective? Meantime, for people like this person who asked the question, boy, someone with primary immunodeficiency or acquired immunodeficiency because of transplant or immunosuppression that we give to them as doctors, these are our most vulnerable members of society. They must have a ring of protection. They must be in contact with no one who has done anything as a shortcut. Everyone they're in contact with should take this seriously. They should all be immunized. They should all take their responsibility seriously. They should not be in contact with people who may have COVID-19, because those individuals, if they catch the infection, will have a much tougher time fighting it off. We do take it seriously, and I appreciate that question.
So, Dr. Pottinger, I'm going to talk a little bit about the anxiety that parents are facing today. They're sending their kids to school amongst this, very high infectivity rates of Omicron. Cases are rising every day. Parents like me, we are really worried sending off our kids to school. We don't know, when either one of their classmates tests positive and then we need to keep them home, or B, they start developing symptoms and then we cannot show up to work. We have to get tested and such. So there's a lot of anxiety and worry, rightfully so, amongst parents. Can you tell us a little bit about, about school transmission, if that's available, the data is available? And as the other thing is, what would you advise kids at school? How can they be safe during lunch, in the classroom, in the music room? What are some of the things that we as parents can do for our kids or teach them to, avoid getting infected?
Yeah, thank you so much. It's a great question. I've struggled with this. I have 2 kids in school myself. I think you should make your voice heard, both within the family structure by telling your kids that you take it seriously and coaching them on the importance of their own personal responsibility, but also working with school administrators. We know what works. We know this. We know that immunizations combined with careful, high-quality masking, combined with staying home if there are symptoms or an exposure, combined with testing where available, these things matter. They definitely work. But as we take away individual elements, then the protection that we have is less. This leads to very high stress. This is a huge issue. And so I do take it seriously. We're trying to balance the wellness and mental health of our kids. We want them to be in person, at least I do. I think being in person in school is just a huge benefit. Zooming like this is just drudgery. I'm saying that I'd love to be connected to you today, but let's face it, we're all zoomed out. So our kids really should benefit from that. But holy cow, if they go into an unsafe environment, then it just will not work. To answer your question, lots of transmission that we are seeing in schools where these elements are missing. Alternatively, in schools where the elements are in place, transmission from one masked person to another masked person is uncommon, especially if we're talking about real masking. I mean, the masks work combined with immunization, right? So I think that's important. I would take a hard look at the way that your school administrators and leaders are responding to the pandemic. If there's a mindful, holistic process and these elements are in place, then I think you can be de-stressed. It's not that it's perfect, but I think that can be much safer. The elements of risk that are always there are when we take our masks down. So that's usually eating, singing, playing a clarinet, something like this. This should be done in a very thoughtful way. Eating outdoors is much safer than eating indoors. Eating with personal space is much safer than eating crowded together. Some schools will have the ability to do this. Other schools may not. And I think that's something that should be looked at very specifically. I wouldn't just ask about the philosophy of the principal. I would say, what do we do when kids are unmasked? When is this allowed to happen? That's important. Do you allow, and then it's a numbers game, right? Do you allow visitors to come to spectate in sports from outside schools? That dramatically increases the number of people yelling and cheering on their kids. That's what we all want to do, is cheer on our kids. And yet if it's in an indoor space with strangers from other schools who may or may not be immunized, that is a high risk situation. So I think that individual assessment within the family group and within the school community is what I would advise people to do. Everyone's risk threshold will be different. Some people will never feel comfortable with their kids in schools. Others, well, they don't seem to care too much. Most of us are somewhere in between. Have that conversation within your family and with other leaders in the school and other parents, and try to come to some sort of common understanding. I really feel so badly about the idea that there would be kids who would go to school masked and behaving appropriately with classmates, or heaven help us, staff who are not behaving that way. That dog won't hunt. That will not do. I think we should all insist that everybody step up and take care of each other. And if people do, then I think school really can be a safe and amazing thing.
So I think, Dr. Pottinger, eating outside if possible, and if the school has that ability to have kids sit outside and eat, is a really safe practice. In addition to, of course, masking and appropriate masking and improving ventilation. Opening windows. Perhaps it's very cold, I know, but those are some kind of some of the things that can help mitigate the risk. The second question is, I really want to acknowledge the parents of kids who are younger than 5 years old. What about them? They are really feeling distressed. And there was an article in the newspaper recently about how, stress, how much stress that's causing them. Are the vaccines in the wings for them? Should we expect that the vaccine will be here soon for kids younger than 5?
I sure hope so. I mean, it would just be a game changer if we had that delivery. I don't have inside information. I don't sit on that committee at FDA, and I'm not on ACIP, so I don't know the timing of what that looks like. I sure wish we had it today. But again, I think the reason we don't is that people want to do this very thoughtfully, carefully, and to ensure that whatever we do, that it's safe. We really do have to study this. So as you'll see, as the age for inclusion with different immunization products gets lower and lower, that's because we have more and more data to show us that it's a safe, effective thing to do. Children are not little adults. They are physiologically different, and where that transition happens from being a little creature that's a different person to someone who's just slightly shorter but immunologically mature, it's a spectrum. And that's why experts who are doing these clinical trials have to do so very thoughtfully. Sometimes it's vexing, because you may have someone who's just a couple of months short of a particular cutoff. I mean, that drives us crazy. It's probably not biologically important, but the reality is that's how the trials are done. We have these arbitrary age cutoffs. So to answer your question, I'm very hopeful that we will soon get the ability to immunize our youngest members of population. Meantime, we don't have that. Meantime, we have to ask ourselves, is a little kid going to be able to mask appropriately or not? That may not be something that's feasible. With that in mind, you're correct, Anita. These families are in a really tough spot with respect to childcare, elementary, early education, etc., whether it's through the lens of a school or through a daycare program. We are seeing a ton of transmission in those populations. And so I think if someone is on the fence about this, if they're worried about a child, certainly if anyone within the family has immune suppressed situation or is at risk of progressing to bad COVID, I'm talking about a grandparent or parent with diabetes, heart disease, lung disease, those are the kids where it would be quite reasonable to consider keeping them home until we get past this surge. That's easy for me to say. It's hard for people to do, right? Because not everyone has the ability to telework, and if they're teleworking, they're not taking care of a kid. This is why it's an emergency. This is why it's a crisis that's threatening the fabric of our society. What are the hopeful things that I would put out about kids and all of us in general? Based on the numbers we're seeing preliminarily from places like New York and Boston, large centers on the East Coast, it looks like they are starting to plateau out. We suspect that we will probably go a similar direction to places like South Africa or the UK, that will see a precipitous drop as well. I don't know that it'll be the exact same timeline. We don't have as many Americans fully immunized and boosted as some of these other countries do. So we seem to drag things out here in the US. It's true politically, it's true for medical science. So I suspect that we'll have a longer tail. But I'm hopeful that in the next 4 weeks that Omicron is going to be largely in the rearview mirror, and we'll be looking ahead to the next variant. Yes, I said it. We may have yet another variant. I would like to think this is the death knell, the last gasp of COVID-19. I don't have any reason to think that's true. These variants seem to keep coming and coming. The hope is that as they come, they will be less and less virulent, more and more tolerated, and less dangerous over time. I think that's the general trend we'll see. But just like we see with flu, which has been around since forever, we have bad years for flu and good years, or less bad years. We're probably going to see the same thing with coronavirus. I think it's likely to become an endemic virus, something that's always being spread from person to person, and that in the seasons of the winter, we'll have times that are worse and maybe a little bit less worse. I'm just spitballing. Nobody knows. It's the future. If I could read the future, I'd be a different guy. But that's my prediction.
Thank you so much. And so you also answered the question about the peak, hopefully the peak of Omicron. So we can expect it in the next 4 weeks. Is that right to assume?
Oh, that's not coming from me. That's coming from people way smarter than me. Our epidemiologists and virologists, people at IHME, for example, who are doing the modeling. That's the hope. We'll see how it goes. It'll really help if people get those shots, boosters, and stay well protected and behave responsibly. Again, the virus doesn't care. That's a social question. It's less of an infection question, which is what I do.
Dr. Pottinger, the next question is this really important about to address the confusion around the CDC guidelines for quarantine? How many days should people quarantine after they test positive? When can they go back to work? Please, if you could address that.
Yeah, happy to. Thank you. You'll see, I appreciate that a lot. And so you'll see these terms used interchangeably in the media. Technically speaking, if someone is sick, we remove them from society. We call that isolation. If someone is exposed but feels well, we remove them from society. We call that quarantine. You'll see people use this interchangeably. So for someone who's ill with COVID, either because they feel sick or because they have a positive test and they don't yet feel the effects, we call that asymptomatic infection. In either case, we want those people to isolate. They should not spread it around to others. So they need to stay home. And the question is how long? This has become confusing because of some updates to guidance recently, but don't be confused. It's actually very simple. We have always known that time is on our side, that the infection will be there and transmissible. When it's most transmissible is when we are least symptomatic. That's why this spreads like crazy. But having said so, from the time we're infected to the time we're no longer contagious to others, that time initially, as you may recall with Alpha, we used to call that 14 days, 2 weeks. That works. Virtually never will someone spread it around after 14 days, unless they have immunodeficiency chemotherapy. Those people can actually shed or spread for a longer period of time. So 14 days works. 14 days sucks, and it's also arbitrary. It's 2 weeks, and a week happens to be 7 days. That's how we came up with that. So then there was science that said, does it really need to be 14? How often do people spread beyond 10 days? And it turns out that that is also very uncommon. 10 days is safe for most people who are infected. And when I say 10 days, I mean from the onset of symptoms or a positive test, whichever may apply for those who don't have symptoms. So 10 days works as well. Can you spread it to others beyond 10 days? It's possible. If you're immunosuppressed, that happens, but most people will be non-communicable at 10 days. So that's still our guidance, that if someone is infected, they should stay out of society for 10 days. 10 because most of us were born with 10 fingers. That's how we came up with that. It also happens to be virologically true. That's as true today with Omicron as it was with Delta, Alpha, everything else. So where does 5 come from? What CDC has said is, okay, 10 days works and it's safe, but holy cow, it kind of stinks because then people can't go to work. We don't have people driving trucks. We can't take an airline flight. Our nurses are out because they've been infected. Can we make it shorter? And what very smart people at CDC realized was, yes, we can. This can be reduced in certain criteria. So you can move it from stay home for 10 days to stay home for as early as potentially 5 days if you meet certain criteria. What are those criteria? The criteria are you should have no more symptoms or very mild minimal symptoms. You should have no fever. That means no fever for at least 24 hours without taking Tylenol or other fever-reducing medicines. And ideally, you should also have a negative test. Not a PCR test, but that antigen test. Remember that antigen test we talked about, how it's rotten early in infection? Well, it's great later in infection, because once it goes negative, it means that your chance of communicating that infection is really reduced. So that's what, and you should also, by the way, have a normal immune system. So people with a normal immune system who have resolution or dramatic improvement in their symptoms, they're not taking Tylenol, they have no fever, and it's been at least 5 days, and they have a negative test. Those folks can go out of the house if they are willing to carefully mask with a high-quality mask and only be around other people when absolutely necessary, for at least those next 5 days, getting to the magical 10. So because of all those caveats, this all got jumbled around. So I wish that CDC, I admire people and friends at CDC, I know those folks, they're very good. What I wish they had done was to say it's still 10 unless you meet these criteria. And I think the message came out as it's 5 except, and I wish they had said it's 10 unless. And so anyway, that's where we are. I know that testing is not easily available, and thus, if you cannot have access to a test, can you go out earlier than 10 days? If you must, do, but please, for goodness sakes, make sure that you are asymptomatic, that your fever has resolved, that you really feel able to get out of the house, and for goodness sakes, please wear that high-quality mask, because you are absolutely, possibly still able to shed and spread that infection. So thanks for behaving well with others in mind, too.
Dr. Pottinger, there have been patients who have been using the antigen tests and they keep testing positive. It keeps showing a positive result even after 5 days or 10 days. What should they do? Are they still considered infectious?
They may be. This is the concern. And I mentioned that almost nobody is contagious beyond 10 days, but some people are. And that's where the benefit of testing comes in. That's different from PCR tests. PCR tests are so hypersensitive. They can stay positive for weeks. I don't need a negative PCR, but I would love to have a negative antigen test. For those who have lingering, stuttering positivity of their test, I would ask those people to stay in isolation, or at least to minimize their time outside of the home, and when they do, to be masked up. Yes, those people should consider themselves to be infectious and contagious to others.
Thank you. Dr. Pottinger, do you have to take off at this time?
I have another, I could do another 2 minutes if that's okay.
Okay, so let's ask you this last question. There's a question in the Q&A. What is the likelihood that future COVID waves will have vaccine escape or immune invasion? And what percentage of the world needs to be vaccinated to end this pandemic?
Yeah, thank you. I don't know the answer to either question. These are the questions I ask myself in the middle of the night as well. Based on our previous history with and knowing the biology of this particular virus, I think what we're finding is that the current vaccine technology provides protection from variant to variant, but that level of protection will vary against the different variants. And so that makes the second question impossible to answer. What's the proportion that we need to immunize? If we had broad cross-protectivity with one vaccine that covers all of the different variants, then presumably that number could be lower in terms of who needs to be immunized. That's not what we have seen. We do not yet have what we call a pan-genotypic immunization, one shot to rule them all. I don't know that we ever will. It's possible. At the moment, our vaccines go against the spike. That's the part of the virus that sticks to our respiratory tree. It's highly variable. That's what these variants are all about. That's why we call them variants. And thus, that strategy of immunization feels like we're often playing catch-up, although there is some cross-protectivity for sure. On the other hand, if we go not for the spike, but for the nucleocapsid, for something at the core of the virus, which is less likely to vary, it's possible that we will end up with such a technology. That's where Nobel Prizes are born and made and well earned. So I'm hopeful that that will happen. The reality is that I think we are still a long way away from being done. I hope I'm wrong, but I doubt it. So much of our world is unimmunized, and as we are getting our third, potentially fourth dose and beyond, most people in the world haven't got a single shot yet. We have a lot of work to do with equity and access worldwide. And if there's one thing we've learned about COVID-19, is that we're all connected. All this grand ship, Mother Earth, we are in this place together, and all people are connected. So we have to do better about getting more pan-genotypic or broadly protective vaccines out to everybody, regardless of where they live, who they are, their skin color, etc. We have a lot more work to do that way as a species. I'm doing my little part here, but thanks for helping us and think about ways to make accessibility of this technology more globally available. I'm so appreciative to be connected to all of you. I'm so sorry that I do have to go to my next thing. If there are other questions that come up, and I think there may be many of them, I wonder whether you, Anita, or Priscilla at the office are able to somehow field them. I'd be happy to try to respond individually to people electronically. I'm happy to offer that, even though I can't do so now in person.
Thank you so much, Dr. Pottinger, for your time, and thank you for making this such an invaluable session. This was much needed for the community, and I really, really appreciate your time today. Thank you.
It's a pleasure. Thank you all, and I hope everyone is well. And thanks for your thoughts and for your hard work in this problem.
Thank you everyone
you.
for joining. In the chat, I've put a link where the recording of this session will be uploaded. You can also find recordings of our past sessions on there as well. Feel free to share that link out to any of your loved ones. And we will plan to do another session in the near future. Thank you so much for joining.
Thank you.
Thank you.